like to invite on stage Dr. Manjunath, Senior Consultant, Nephrology and Transplant Physician at Fortis Hospital, Nagarbhavi. Please welcome Dr. Manjunath.
Today I'll be talking about on medical management of difficult renal transplants. Any person with chronic kidney disease progressing to end-stage kidney disease, that is CKD stage 5, would require a renal replacement therapy, either in the form of hemodialysis, peritoneal dialysis, or kidney transplantation. And a successful renal transplant depends on multiple factors. Mainly it's the immunological factors, donor factors, recipient factors, as well as the post-transplant complications like infection and rejection. Coming to the immunological risk in renal transplantation, any donor and recipient pair, before proceeding with further evaluation, we assess for the blood group compatibility, that's a blood group match and the tissue cross match. Here generally the blood group compatibility, it follows the transfusion compatibility. It's like O is the universal donor and he can donate to either A, B or AB, whereas AB can receive the kidney from the other blood group, all the three blood groups, as well as AB also. Whereas if a O becomes a patient, the recipient, it becomes difficult to take the kidney from the other blood group like A and B or AB. Since the A as like O group has antibodies, like he has to, like, this will become an incompatible transplant and we need to remove the antibodies which are present in the recipient to make it a transplant possible. This is the immunosuppression protocol what we follow for in ABO incompatible transplants. First, initially we give the rituximab to prevent the production of new antibodies, then followed by the plasma exchange or the cytosorb therapy to remove the pre-existing antibodies, then followed by the sequential immunosuppression with ATG as an induction, then followed by the triple immunosuppression. In a sense, the next is HLA sensitized individuals. That's any anti-HLA antibodies in the recipient against the HLA antigens of the donor would cause rejection. It can be an hyperacute rejection or an acute rejection, and this sensitization can happen following a transplant or previous blood transfusions or pregnancies. Here, the desensitization similar to the ABO incompatible transplants is followed, except this immunoadsorption where we use anti-A or anti-B column. Here we are going to use anti-HLA and remove the antibodies which are pre-existing and make the transplant possible. Then coming to the donor-related factors, we see more of a expanded criteria donors. This actually it means any donor with an age of more than 60 years or having hypertension or creatinine 1.5 more than 1.5 and CVA as a cause of death. They are accepted, the kidneys are accepted to increase the donor pool, and we have seen good results with the expanded donor criteria. And in the living donors, we have encountered both the age groups, like older age group as well as the younger age group. And if there is no other suitable donors, we have to, we can do the elder donor as we can accept the kidney from the elder donors. Coming to the next donor factors, the anatomical abnormalities like multiple vessels, at the same time small pediatric in case of a deceased donor where en-bloc kidneys are removed and implanted to the recipient. Coming to the recipient related factors, the recipient factors like poorly controlled diabetes, having the microvascular as well as macrovascular complications can have an effect on the post-transplant outcome. And at the same time, cardiovascular diseases, COPD, obesity with BMI of more than 32, and previous viral infections, especially the retroviral infections, hepatitis B, C, as well as the recurrent urinary tract infections, old tuberculosis, fungal infections. This becomes difficult to manage following the post-transplant, where we'll be giving a lot of immunosuppression to keep their immunity under control so that the body accepts the kidney. To prevent the infections in the post-transplant, we will be giving the prophylactic antibiotics as well as antiviral and antifungal. There are risks of recurrent disease in the graft, like especially in the pediatric age group, we see a recurrence of FSGS, IgA nephropathy, and lupus nephritis. For these patients, we monitor for the recurrence and do a graft biopsy, then followed by the appropriate immunosuppression. The other factors are in elderly patients, especially the more than 60 years with other comorbid conditions. They require a tailored immunosuppression and post-transplant care to prevent infections in the long run. Coming to the surgical and technical challenges which can cause a delayed graft function or slow graft function, like multiple renal arteries or multiple veins, ectopic kidney, these can delay the graft function and sometimes may need dialysis support for some time. And previous surgeries can complicate the procedure and require a long time to engraft the kidney and cause a delayed graft function. And urological issues like bladder dysfunction, bladder outlet obstruction can need additional interventions, as well as they need a catheter placement for a longer duration, increasing the risk of infection. These are the cases where we need to screen appropriately, regularly for the infection and take appropriate measures. Post-transplant complications commonly encountered are acute rejection, which can be immediately on table, like a hyperacute in a sensitized individual. And at the same time, early or late rejection, which are commonly seen following non-compliance with the medications, where the biopsy is done, and depending on the type of rejection, we need to give immunosuppression as well as plasma exchange. The other complications which are encountered during the post-transplant period is opportunistic infections and malignancy. Most commonly, the CME and BK virus we see in the first 3 months, as well as the reactivation of tuberculosis. In the long run, the post-transplant lymphoproliferative disorders can happen, and we need to keep a track of this occurrence of this malignancy, which is noted up to 5 to 10% in the long run. And the medication non-adherence, usually the patient takes very lightly after some time, like 3 to 6 months. Then if they miss the medications, definitely they will have the rejection. It can be an antibody-mediated rejection or cellular rejection. And if the rejection is severe, it can lead to a graft loss, and we need to counsel regarding the continuation of the medications as well as a regular follow-up. These are the transplant patients, the cases we had in the last 1.5 years. These are the ABO incompatible transplants. We had all age group across all the blood groups, like donor being A and the recipient being O. It's across the blood group, and at the same time the other blood group also we have done. And even the age we have done across the elderly patient recipient to an younger patient. And this is a result what we can see. That means the ABO incompatible transplant is a viable option in case if there is a need. And this is we had 2 patients with HLA sensitization, and these required a desensitization followed by the second transplant. And this is the values what you can see on the graph. They had a good normal graft function after the transplant following a desensitization. These are the other group of patients where we can see the recipient being a 30-year and the donor age up to 71 years. This is the expanded criteria donors are accepted, and we can see the results. Creatinine is 1.6, which is quite acceptable for a 71-year-old donor transplanting to a 30. And the other, you can see in the deceased donor, where we are seeing we are not wasting organs, and trying to utilize more organs and give a transplant to the patients waiting on the list for the cadaveric organ. This is a lady who had a BMI of 42 and with diabetic related micro and macrovascular diseases. You can see the results following a transplant with son as a donor. After 1 year, the creatinine is 1 and she is maintaining well in general. These are the two patients who were like retropositive, who were transplanted at our center. This basically the criteria for transplanting a retroviral positive is the CD count should be more than 200 and viral load should be undetectable, and they should be stable on an antiretroviral drug. Here we change the drug from a protease inhibitor to an integrase inhibitor, which doesn't interact with tacrolimus, and we can see the results. Like creatinine is 1 even after 1 year of follow-up, and that means the retroviral patients can also be optimized and taken for a transplant. This is the second case. This is an Ugandan who had a transplant with a brother as a donor, and his creatinine is 1.4. That means even infected cases also we can modify the immunosuppression as well as give the appropriate antiviral drug and do the transplant. These two are hepatitis B positive patients, and you can see the creatinine value, which is almost near normal. Here basically we give the vaccination to the recipient. These are the donor being the positive. We vaccinate them before 2 weeks of the transplant. At the same time, on day -2, we give the passive immunization with immunoglobulin, and then followed by the transplant. These are the few pediatric patients who had had a challenge during the transplants. It was a challenging cases. The first one was a Oman patient from the Oman having obstructive uropathy. Then the father was a donor, and he had multiple other issues like a subdural hematoma, seizure disorder, and a DVT requiring a IVC filter. Here it was a ABO incompatible transplant. At the same time, he had multiple other comorbid conditions. His creatinine came down to 1.8 and he's doing well even after one year and is under regular follow-up. The other case is a 4-year-old boy who was a prematurely born twin, and he had a posterior urethral valve requiring a nephrectomy with metrophenol. And here the donor was his grandmother, and his creatinine is 0.6 and is doing well. In the pediatric population, the challenge is the bigger graft requiring the surgical expert in doing the anastomosis. At the same time, when a big kidney is transplanted, there can be a drop in pressures, intra-op and post-op. Optimizing the blood pressure and fluid management becomes a challenging, and at the same time abdominal closure also it's a challenge. Sometimes it can lead to abdominal compartment syndrome. The other case is a 10-year-old boy who underwent a renal transplant. This was a steroid resistant, the congenital FSGS. This patient had a initial recovery of good recovery with the creatinine of 0.8, and subsequently later after 3 months started having proteinuria, and the biopsy showed a recurrence of FSGS in the graft, and he underwent a plasma exchange as well as rituximab. Then the immunosuppression was modified to cyclophosphamide, steroid and tacrolimus, and now he is listed for a newer drug for the recurrence of FSGS, and his creatinine is normal but has a mild proteinuria which is manageable. And in conclusion, renal transplantation carries good long-term outcome. In a compatible transplant, the outcome is like the half-life is around 13 to 14 years, and in a cadaveric transplant, it's around 8 to 10 years. And the graft as well as the patient survival is more than 95% in a compatible transplant. And in a ABO incompatible or HLA sensitized, it's almost 85 to 90%, which is quite good. Any patient on dialysis, the yearly mortality is almost like a 20%. and compared to that, renal transplant definitely carries a good long-term outcome, and at the same time it's a better option compared to dialysis in terms of quality of life as well as longevity of life. And it's the renal transplantation is increasingly becoming common and quite accepted. And when we compare the cost of dialysis, the patient spending, it would be like on an average 25 to 30,000 per month. In a year, it would come around 3 to 4 lakhs, including the medications, dialysis cost, as well as investigation. In 4 to 5 years, it would be spending around 20 lakhs. If half of it is, if it is spent on transplantation, definitely the quality of life would be better, as well as longevity of life will be better. And at the same time, it requires the patient education and counseling. When it comes to a marginal donor or ABO incompatible, when there are no suitable donor in the family, even if there is a blood group mismatch or an HLA sensitized, we can definitely give a desensitization and do the transplant. Thank you.